Hi, my name is Yi-Bin Chen. I direct the transplant program at Mass General Hospital in Boston, and it gives me great pleasure to be able to speak today about this. And it's a topic I've been very interested in over the last decade and a half of my career. I'm asked to talk about sorafenib is now the standard of care as maintenance therapy after allogeneic transplantation for patients with FLT3 TD mutated acute myeloid leukemia. I think we should, before we address that topic, we should take a step back and appreciate the advances we've made in treating these patients. When I first started, patients with FLT3 ITD mutated AML had a dismal prognosis, and we were able to achieve a durable remission or a quote unquote cure for patients in a small minority. Several advances have been made, including more accurate diagnostics, understanding of prognostication with co-mutations and other clinical factors. I think we're all aware of the incorporation of midostatorin as initial therapy for younger patients with intensive chemotherapy, and then the incorporation of other FLT3 inhibitors throughout other aspects or other phases of their care. I think we all believe that allogeneic transplantation is the optimal and best consolidative therapy for the vast majority of patients with FLT3 ITD mutated AML. There are certain subsets that are controversial, such as those with concurrent NPM1 mutations or low allelic ratios. But here at Mass General, we offer allogeneic transplantation for any patient with a detectable FLT3 ITD mutation. And the outcomes speak for themselves in terms of the improvements in prognosis over a chemotherapy consolidative approach. Back in the early 2010 area, we had several patients who we were very frustrated with that had quick relapses after allogeneic transplantation with FLT3 mutated disease. And we had just started to test FLT3 inhibitors. None of them were yet approved, yet this agent called sorafenib had been approved in several solid tumor malignancies, and so there was some commercial access. And so in 2014, we put together, or at least in 2011, we put together an investigator-initiated trial to test the use of sorafenib as maintenance therapy after transplant for these patients. And those results, which were first published in 2014, really surpassed any of our expectations, showing remarkably low relapse rates and a reasonable safety profile after transplant. Since then, the use of FLT3 inhibitors as maintenance therapy has somewhat taken off. There have been several randomized trials conducted, most notably out of Germany, the SORMAIN trial, as well as out of China. And both of those randomized trials would suggest a significant benefit to maintenance therapy after transplant for these patients, showing 2-year disease-free survival rates approaching 75 to 80%, which was a significant improvement upon our past experience. It should be pointed out that the vast majority or all of these patients in these trials that were studied did not receive FLT3 inhibitors as part of their initial therapy, and we don't truly have an understanding of if certain populations drove the benefit here if we factor in modern measurements of prognosis, such as measurable residual disease assays that have truly helped us prognosticate for this group of patients. So I guess the question is fair. Is sorafenib the standard at the moment? I would say FLT3 inhibitors are the standard to give as maintenance therapy after allogeneic transplantation. I think the question is the choice of the agent. And a lot of it depends on where you practice, what's available, what the patient has tolerated, and what the toxicities are. Midostaurin is available for certain patients. Its advantages are that it also targets the tyrosine kinase domain mutation, and it does hit other kinases as well, and so it might provide that benefit. And it's available. Sorafenib is available, but it's not approved in AML, and so there are issues with access. But if you're able to access it, it's a fine drug to give. There are certain toxicities to understand, such as that of the skin and of the GI tract, but usually with dose modifications, it's quite tolerable. And gilteritinib is available, at least where we practice in the United States, and we find that to be the most tolerable TKI in any setting, and specifically after transplantation. It also hits the tyrosine kinase domain mutation as well, which is important for a small subset of patients from a resistance perspective. So for now, for us, gilteritinib is the standard just because we find it the most tolerable And I believe that the issue is just getting some FLT3 inhibition after transplant. The agent per se doesn't seem to matter at the moment, and I'm not sure we will have any head-to-head prospective comparisons of TKIs to each other. So it really all comes down to what agent do you have access to. But I think in the end, the bigger message is how much improvement we've made. We've taken a biologically defined subset of AML that was initially regarded as very poor risk, and now with modern treatment approaches, they have a very favorable prognosis in the long run. So thank you very much for your attention.